I think so. Okay. Just a minute, because I am not able to see it. Probably there is some problem.
The Italian guys come.
Yeah. Dr.
Yeah,
Alberto,
Alberto is here.
Alberto is here.
Alberto Gobi.
No, Constantine.
Alberto Constantini. He is a very famous shoulder surgeon, consultant with Arthrex, and he has got certain publications in shoulder. Alberto, can you hear us?
Yeah.
Yes, he's there.
I think we will start with the program now. We are live on YouTube. So I'll just request the moderators for the day. We have the program, which is the Rotator Cuff Part 3. And we have two speakers. One is Dr. Jayaprasad from Hyderabad and Dr. Alberto Constantini. He is from Rome, Italy. He is a wonderful shoulder surgeon and expert in shoulder who has got many publications in shoulder, especially on biceps and rotator cuff. Then we have the moderators in the form of Dr. Vivek Pandey, Karthik Selvaraj, Rajiv Raman. Rajiv. Hi, Rajiv. Rajiv, Dr. Sanjay Trivedi, Dr. Rajkumar Amravati. And we have panelists, Dr. Abhay Narvekar, Vinay Tantoe, Umesh Jadhav, Krunal Shah, Raghuvar Reddy. Raghuvar is joining in some minute. Swarnendu Samanta probably will not be able to join because of some other commitment. Vinay Pandey. Vinay, hi, Vinay. Saurabh Mathur, Arun Gupta, and Mihir Patel. So we have the main coordinators, Dr. Nicholas Antao and Dr. Roshan Wade. So I'll request two moderators for the day, Dr. Sanjay Trivedi and Dr. Rajiv Raman, to proceed with the program. I think both of you have the program, Sanjay bhai and Rajiv. So
Rajiv, please do the honors.
Yeah, thank you, Sanjay, boss. So thanks to Arthroscopy Academy for Rotator Cuff Part 3. And we have very well-known faculty, Dr. Jaya Prasad from India and Dr. Alberto from Italy. So first talk is from Dr. Jaya Prasad. I think, Jaya, you can share your screen.
Buongiorno, Dr. Albertini.
Buongiorno.
Nicholas sir is very good in
Italian,
yeah?
He can greet you in 15 languages.
15 languages.
Nasimara.
Okay, I'll just mute everyone, JJP. Just
Yes.
a minute. I'll mute everyone so that you can. Okay, JP, you can go ahead.
So, good evening, everyone. Roshan, are you able to hear? Hello?
You're audible and your slide is visible.
Okay.
Yes, you're audible.
Okay.
We can see.
Yeah. So thank you, Roshan, for giving the opportunity. I'm going to talk on the factors enhancing the rotator cuff healing. So we know the rotator cuff surgeries are very advanced surgeries with a double row, single row, and there are a lot of instrumentation, implants. In spite of that, we have a failure rate of 13 to 94% in our literature. So what are the causes for this failure? So this is a study done very recently, the healing rate of the rotator cuff repair. There are the different studies by the different authors. The healing rate, if you see here, this study is around 12% healing rate. And if you say Lafossi's healing rate is 88% and the Pascal's is 70%, 71%. So around 20 to 30% of the rotator cuff doesn't heal. So what are the problems with the here? What are the risk factors for the re-tear? Are they not getting really the healing at the tendon and bone junction? One is a size. Next one is a factors, fatty degeneration. Third one is a smoking, old age, delamination of the rotator cuff, and longer symptoms and symptom duration. After the injury, the patient coming to the surgeon, there will be a huge time gap. So that is one of the factor. And tension, high tension repairs and fatty degeneration. These are the different factors which will influence the rotator cuff healing. So last 2 decades, there is a significant research to overcome this repair rate. there are a lot of development in the biological augmentations like growth factors, platelet concentrates, cells, scaffolds, and drugs, and the combination for all these different factors. And if you come to the basics, the reason for this high failure rate may be due to the intrinsic degenerative changes of the muscular tendinous unit. Uh, so when there is a tear, the muscle gets retracted and degenerative, and that you get atrophy, and the progressive loss of muscle volume due to the loss of sarcomeres. If you see here, this is a sarcomere of the muscle, and when there is a tendon tear, the muscle will get atrophied because of sarcomere loss. And there is a change in the pinnate angle. The pinnate angle is the long axis of the tendon. When there is a muscle, there is a tear here. What happens is this is the angle between the long axis of the muscle tendon and with the fibers, muscle fibers. If it is a bipinnate muscle, these are the fibers like this. There is an angle which it should be a 30 degrees angle. If it is more than 30 degrees, what happens is the muscle will get collapsed, and these are the muscle fibers where the intramuscle or intramyofibril or the intermyofibrillar area will be triggered by the loss of myogenic precursor cells and causes adipogenic pathway where these areas will be filled with the adipose tissue, so that there will be muscle loss and the fatty or adipose tissue deposition in this area causes the irreversible loss of the muscle tendon unit. So what are the different healing process, or how it happens, what are the stages? The inflammatory stages, repair stage and remodeling stage, these may overlap, but the basically inflammatory stage will be 0 to 7 days, and repair stage will be between 5 to 25 days, and remodeling stage will be after the 21 days. So in inflammatory stage, where there is a cytokines will be released, which will cause the inflammation at the site of the injured site. These are the very important cytokines which will trigger the inflammation and repair. And what are the factors, biological factors, which will hamper the healing? One is the increasing age. This is a very important risk factor. This article by the Pascal, he has published in 2005 in JBJS. He has compared the patient with a rotator cuff over the age of 65 and below the age of 65. There is a significantly lower rates of healing in patients who has over the age of 65 years. Definitely, the age is a factor here. And this study he has done in age of 65 years patients, but he has taken in a small group or single tendon tear, but he doesn't have any negative results. And here in again, Engel paper in 2009, he has published the similar result. He has compared the 50 years and more than 51 years age group. There is a difference in the healing stage, healing rate. There is 79 if it is more than 51 years, and 87% in the patient who has less than 50 years. Again, another study, the age is definitely influences the healing rate, and age is not only the independent factor. There are other factors also influences. So we have to consider the age is one of the factor for healing of your bone tendon junction. And smoking is another factor, and this study is done on the rat model, where the nicotine group on non-nicotine group, they compared nicotine group rats. There will be a chronic inflammation, decreased the cellular proliferation at the bone tendon healing junction. So in clinical study, So this was published in again same the nicotine. They have divided the or analyzed the nicotine on the bone tendon junction healing. It is a dose dependent time, how much time he has he was in smoking per year, per day, how many cigars he has he has taken in the day. These are all they analyze. The cigarette smoking is another important factor for the tendon bone healing. And you need to talk with the patient to stop the nicotine when you are operating before operating the patient. This will give a good results. This is a another factor is diabetes mellitus. Diabetes mellitus also influences this rat model study done. The group, one group is glycated hemoglobin of more than 10, and another group is glycated hemoglobin of less than 6. This here the diabetic animals demonstrated significantly less fibrocartilage and organized collagen. And in clinical study, definitely there are more complications in the diabetes patients and the poor healing rate. So diabetes is another contributing factor for the rotator cuff healing. So you can change this factor into normal after getting a near normal, or glycated will go into near 6 and then operating these patients. And anti-inflammatory again is also an hampering factor in the bone tendon healing. And initially there are studies, there is a positive influence remodeling of collagen matrix during the initial stages of the tear, but later it will hamper the bone tendon healing. So, and another factor is hypercholesterolemia. So people who have the high cholesterol is getting less blood supply because of the atherosclerotic area, arteries and the tendon. So then you have to prime this patient before treating your rotator cuff repair. And vitamin D, there are studies, no correlation between the vitamin D deficiency and the bone tendon healing. And this, so here if you see the normal tendon, there is 4 zones: tendon, unmineralized fibrocartilage, and mineralized fibrocartilage and bone. And this is after repair. If you see here, this one is a tendon area, and unmineralized. This one is a tendon area, and this one is unmineralized fibrocartilaginous area, and this fibrocartilage area. This is a bone. So what happens is when there is a tear and repair, the entire thing will be changed. This one is a suture, and this is a fibrocartilaginous area, and this is the entire pattern will change. That will gives a very lesser bone healing capacity. So the growth factors in the healing, there are multiple studies about the growth factors. One is tumor growth factor and tumor growth factor beta 1 and beta T3 and BMPs, BMP2 and BMP7. So these are all influences the bone tendon healing. But there is no difference in the respect to the maximum load to failure. But initially there is improvement in the bone tendon healing. So, using platelet-rich PRPs. There are 4 types of PRPs. One is LPRP and PPRP. We use these 2 PRPs actually. LPRP, PRF and PRF, PPRF. But we use low leukocyte, high leukocyte, that is LPRP. And low leukocyte PPRP. This we use clinically in the shoulder. And in LPRP, full thickness rotator cuff, like large or massive cuff test, there is no benefit with the LPRP. And a smaller test, definitely there is a useful in the smaller test. And partial thickness tear, rotator cuff test, LPRP is having a good results, good improvement in the bone tendon junction. And this PPRP in full thickness tears, there is a significant difference in the re-tear rate, and partial thickness rotator cuff, there is no study in PPRPs. And LPRF, there is no beneficial effect with the LPRF and in full thickness tear and partial thickness tear. It is not applicable in partial thickness rotator cuff tears. And PPRF in full thickness tear did not show any significant difference in the healing rate. And in partial thickness rotator cuff tears, there is no study. And come to the cell-based augmentation, there are several studies shows there's a reduction in a massive reduction in the mesenchymal stem cells at the bone and tendon junction in the rotator cuff tears. There will be no regeneration, or the healing capacity will be very less. So the stem cells to augment the enthesis, there are two types of stem cells we use. There is embryonic stem cells and adult stem cells. Normally we use adult stem cells, mesenchymal stem cells. I use the BMAC during my rotator cuff repair. This gives a very good results. And this study showed there is a mesenchymal stem cells at the rotator cuff. They compared the mesenchymal stem cells without giving stem cells. There is a 13% of re-tear rate over 10 years of post-operative period comparing to the 46% in control group. And adipose derived stem cells, definitely it is more minimally invasive procedure than the bone marrow stem cell. And it is a good alternative to increase the tendon bone healing. But there is a need for the more animal and human clinical studies to know the benefit of these adipose derived stem cells. And scaffolds. Scaffolds again divided into xenografts, allografts, and synthetic grafts. Xenografts basically, xenografts, allografts are basically they give you structure and environment and improves the healing as well as remodeling. And synthetic grafts basically mechanical strength, not it won't give like xeno or allograft like improving the healing and remodeling. So these are the xenograft people use, like porcine small intestine submucous grafts, and there are several animal and clinical studies and synthetic patch graft. People are using synthetic patch graft. This is a graft jacket. I think now I don't know whether people are using in India or not. It's not available in our place, but the graft jacket is acellular humerodermal matrix. So it's giving a good results in the large massive rotator cuff tears with good results. Thank you very much.
JP, now paper is open for discussion. Rajiv, you have any question for JP?
So the forum panel is open. Any question from any of the panelists? Vinay, Sanjay boss?
Jai Prasad.
Tell me, sir.
Yeah, Nicholas sir, please.
Can I ask a question?
Yes,
Yes, sir, please.
What is the difference between pure PRP and PRP where the cell wall is broken of the platelets?
Yeah, pure PRP is a low leukocyte PRP, and LPRP is a high leukocyte. High leukocyte normally gives inflammation. Low leukocyte doesn't give the inflammation. So that is a difference.
No.
Basically, when you are using for the shoulder or the tendon, we use LPRP, and when you are using a knee joint or other joint intra-articular, we use PPRP, where the low leukocyte PRP.
But there is a new terminology which has been published by Dr. Zoomstein, if I remember, because I was making a talk on PRP. That is LPRF. That is fibrin-rich plasma.
Yes.
Yeah, so I think there is a big terminology mess up in PRP, PRF, and LPRP and PPRP. So yes, please, sir.
I had done some study on this where the cell wall was broken, and we used to inject ultrasound guided and without ultrasound guided. Those factors, the granules directly after preparation from the laboratory. And they gave good results, comparably better with ultrasound guided vis-a-vis, because the publication had come in some international research journal.
It is a very famous paper by Mosaico, no? Use of PRP in rotator cuffs.
Yeah. No. I have not understood the concept of pure PRP, and because again the other day Raman Kugat was saying that he's used poor PRP and rich PRP together.
There is a huge terminology difference in between. Alberto, do you have any knowledge about this orthobiologics in rotator cuffs? Do you use it regularly?
Sir, unmute him, sir.
Alberto, can you hear us, Alberto?
Please unmute. Alberto, please unmute here.
Alberto? Yeah, we can hear you.
I don't have much experience, but we have a paper coming from a guy from north of Italy. Maybe it's Giuseppe Milano, I don't remember the name. And he translates, instead of doing injection of PRP, I know that is concentrated, but what he wants to do, and we start to do, is an acromioplasty, and we leave the blood coming from the upper part of the acromion over the new construct, and we leave on the tendon that you want to repair. But the great problem of healing is the blood, is the vessel. So you can put any dermal, any PRP. The basic point is to promote the vessel to increase the attach of the tendon on the bone.
So basically, you have to create a neovascularization around the distal part of the tendon.
Yeah.
JP, can I ask you one question on enhancing biology? Is there any local factors like microfracture versus, as Dr. Alberto just now said, subacromial decompression and removing some subacromial bone, and microfracture on the humeral side, or maybe tuberoplasty, or maybe some other kind of procedure like augmenting local tissue like biceps can enhance the rotator cuff healing? You have to unmute yourself.
Unmute.
So, microfracture in patients more than 65 years. There are papers. So there won't be any not that much healing potential of that area of the bone marrow. So that is the problem. There are study done. They have taken the bone marrow and seen the mesenchymal stem cells in the rotator cuff tear patients. So there is the mesenchymal stem cells is very less in that part. So when you do microfracture in more than 65 years of age group patients, there is a very less of mesenchymal stem cells, which are the volume wise needed for your massive rotator cuff or large tears. Smaller tears, it is sufficient.
My thought on this is this: if you see, there is a tendency of the factories to use anchor that they call vented. That means that you can use blood coming inside the anchor and go up. I don't like too much macrofracture because that part of the bone is soft. So when the problem is that you screw in the suture, maybe you have a bad pull out. So I prefer use vented suture anchor instead of doing macrofracture.
Yeah, vented suture anchor is always better. The architecture to have the blood out.
And second thing is that I don't use, or I use very little the RF, because use RF close the vessels as much than you can remove with the bore. So even if you use the bore after RF, you didn't reach the blooding vessel downward the bore. So it's better not use the RF on the ball when you clean, when you refresh the bone during tendon insertion.
Jaya, so MSC mesenchymal stem cells or concentrated bone marrow, I think both of them has an increased rate of type 1 collagen production at the tear site. So what is your say on whether you should use a mesenchymal stem cells or a concentrated bone marrow will also do?
Yeah, then I shown in that my paper, this one, my presentation, the bone marrow, also there is a comparative study bone marrow and with the controls. The bone marrow BMAC is giving a good result. And mesenchymal stem cells, if you have a lab and getting a mesenchymal stem separation and getting your product and getting that one is better than the bone marrow.
And any role of hypercholesteremia and diabetes in here?
Definitely. Diabetes, basically the healing rate, they are not pointing out the healing rate. There is a complications are more, and that's what they are stressing in the diabetes. And in hypercholesterolemia, definitely because of hypercholesterolemia, there will be atherosclerosis in the minute blood vessels which supplies the tendon. That will be hampered, that will cause a retear rate. So the healing also will be a problem. That is the reason you prime the patient to have a more HDL than the LDL and triglycerides and total cholesterol, and then you take the patient. That's what the paper says.
JP?
Yeah.
Yeah.
Sir.
Yes, sir.
Now, Alberto said something about subacromial decompression. And the blood coming from there. This is like what you said, directly injecting the bone marrow, right? Without purifying or subjecting to a machine and getting a increased concentrate. Alberto.
Yeah.
Alberto.
Yeah.
You have another famous Alberto Gobi.
Yeah.
About this, you please tell us about his work.
Yeah, now he is more famous than me about this kind of subject. In reality, I don't use much PRP. I just use some in tendon. I use the Artrex PRP concentrated, but it is not my first things to do when I work. And I don't have his facility to conduct the study he does. So my knowledge is very basic and as day life or street knowledge. What I say is street knowledge.
Sir, here the subacromial decompression where the debris, the blood re-injecting. Some paper says basically the tear happened because of the inflammation, the degeneration. There is no potential for the repair. And another thing is there are substances, neurotropic substances which causes a pain. And another one is a substance P also will be located at that area. If you give again that part, the blood which has come out from the debrided part, so then it will cause again inflammation. That is a one theory. And another one is, yeah, definitely it acts like a BMAC.
Vinay, you wanted to say?
JP, it's a nice study, scientific, but you must get the research done in a scientific basis with p-values and all, no? Then it become more authentic. my advice to you.
Yeah.
Dr.
JP, yeah, Vinay, please.
Dr. JP, how long do you wait after repair of rotator cuff before injecting steroids? Suppose somebody has pain 3 months, 6 months. So how do you ever inject steroids after repair? And
No,
if
no,
at all it is,
I never injected
so anyone
steroids.
on the panel, if they have to inject the steroid, how long then you wait?
Inject the steroid, that means that repair will be get damaged. I
Oh,
don't
so
think so. Anybody?
how
In-
long before injecting it?
If patient is not regaining the range of motion,
Yes.
at 4 months, subacromial injection of the steroid is my choice over arthroscopic release to gain the movement.
Okay.
That is
Anyone
what I
else who
do.
is using the
I
steroids?
think that at 3 months and beyond, the healing has progressed reasonably to a stage where steroid cannot do any harm. Rather
Yes.
than it will reduce the inflammation around the capsule and could be helpful. I have not regretted it, and I have seen whenever I have visited either European or American surgeon, I have asked and discussed, and nobody has conclusively said that this is harmful after this many months.
I
I
would
don't know
agree.
the scientific basis.
I would agree with Sanjay. I also do this, but not 3 months, at 6 weeks when I know this patient is very painful. And I
6
think
weeks.
one of the speakers here, I think it was Hero who said that about injection, if I'm not mistaken.
Hiru injects before the surgery.
Yeah.
Sometimes he gets very stiff and inflamed phase rotator cuff tear. Hiru injects and call them back at the 6 weeks. I had
Uh,
discussed this over a dinner with him.
I think
Actually,
we
cuff
have
healing is an inflammatory process, I
inflammatory
think.
process.
Yeah,
Yeah,
so just if you give a steroid, I think you are just negating the inflammatory process. So we need inflammation there, some amount of
so
inflammation.
I think there is no clear-cut guidelines or any research or any publications on
Roshan was
this.
there is a publication which has come recently
Huh?
which says if there is an injection of steroid, you have to wait for 6 months before getting a repair done because re-tear rates are more.
Yes.
So
Yeah,
the
yeah,
duration,
definitely.
the
But
injection
that is
lasts 6
that
months.
is that is pre-surgery, right?
Pre-surgery, yes.
Post-surgery, after surgical repair, use
No,
of steroid.
there is nothing like that.
There is no literature.
Exactly,
I
there
have
is no scientific basis. That's
scientific
what I
basis.
said. That at 4 months, it is not scientific basis.
But
I am
Roshan was
just saving
sometimes,
one
Yeah.
surgery of
Yeah.
release.
but Roshan was
Eh,
sometimes you have to, like, patient is painful after cuff surgery and
I know, but then
need
you have to find out the cause of pain and treat that pain, because I think if your surgery has not solved the issue, again your steroid is not going to solve the issue. So JP,
JP,
I have a
yeah.
question for you. How often you use the bicep to augment the cuff? Because I think a natural uh, the natural vascularized tissue which is locally available can be used for your cuff when in case you have a scarcity of club, the tissue is not good, and you see the less healing potential, especially in the retracted cuff. So how often this surgery? I think this has been proposed by Dr. Young Alri,
yeah, yeah,
and
yeah.
it's a very popular technique.
Yeah, when there is a biceps tenotomy, I definitely resuture the cuff.
So you suture it in a full thickness layer of the cuff, or you just attach it to the rotator cuff?
I will attach to the rotator cuff.
Because Dr. Young Alvi, what he does is he puts a complete bicep tendon onto the from anterior part of the GT to the posterior part, and he fix the GT
Yeah.
first posteriorly, and then he fixes anteriorly, so that it forms a very good layer of the tissue as a lateral, as a what you call the lateral part of the cuff, and then he does a single row repair, so that the single row will work this will work as a lateral row.
JP, but
Okay.
there is one question. What is your opinion about slow and less aggressive rehab? Because that also increases your cuff healing. If you are very aggressive, I think re-tear rates are high in rehabilitation.
Basically, the rotator cuff repair. How good do you have repaired? What is the quality? And the how much is what are the implants you used? And these are the definitely gives important role in your rehabilitation. When there is a degenerative repair, cuff repair, with the massive rotator cuff repair, you should not go very aggressive rotator cuff rehabilitation.
We have
So
we have Dr. Vinay with us. Vinay Tantue, can you hear me, Vinay? Vinay, just unmute yourself. Vinay have got tremendous experience of adipose derived stem cells because he's been using in knee. Vinay, similar use has been promoted in shoulder surgeries as well. Vinay Tantue, can you hear me? I think we lost him. Okay, so Rajiv.
Yeah. So I can, I think we have done with all questions. We can
Yes.
come with more questions in later part of discussion. So now I would like to invite Alberto to share his experience and talk. So please share your screen, Alberto.
Yeah.
Just
This
open your presentation. Yeah.
Yeah.
Hello.
He's
Yeah.
sharing.
Did you see?
Yeah, we can see it. I'll just
Yeah.
mute everyone in a minute.
Yes.
I'll just
Yeah.
mute everyone.
I'll let you know later.
At the beginning for this kind of invitation. And what we say is what we have heard just before, that rotator cuff lesion is very frequent. And as you see, 90% of all shoulder have this kind of pathology, and 30% need surgery. And this is has a nice impact on social life, on working, and as we see, is direct correlation with age, and in general, population is frequent, but especially in sports and in hard worker. So which is the goal of our rotator cuff repair? We want high initial fixation strength. We want to minimize the gap formation and maintain the mechanical stability, at least as we heard, until the biology leads to healing. We have many techniques to repair the cuff, from open surgery to arthroscopic surgery. Basically, what we can see is that we have two group, that is the single group or the single row, and the group of the double row with two row, or double row as we talked today, that is stance osseous equivalent. And we have different technique to achieve these results. So when we think consideration about rotator cuff, we have two-dimensional footprint, because it's 12 to about 24 millimeter. The third dimension, that is contact and is compression of the tendon on the bone, and the quality of the tension of the tendon. We saw that on the paper, we have different paper that talks how is the advantages of the double row repair over single row repair. But the problem, one of the problem, is the cost, that we have a high increase of the cost going from single to double row. And obviously, this cost is related to our facility, to insurance, to the patient. So if we see that from technical and mechanical point, there is a superiority of a double row repair on a single row, if we change the look and looking at the clinical functional result, there is no superiority of double row over a single row. So this is the base of our studies. So one side, we need to justify the implant cost and the surgical times that we have with double row repair. And from the other side, an analysis of risk-reward analysis of patient age, functional demands, the quality of life issue that we have to consider before doing a surgery. So which technique is the best? We have to tailor, as we say, tailor on the patient, on the request. So the age is an important factor, the functional request is an important factor, the quality, the bone quality of the tendon is an important factor, because anyway, as you see in this case, we may have a pull-out. What kind of the type of the lesion is retracted, is not retracted, the shape of the tendon, and at least what kind of skills we have, because this increase the surgical times and, as I say, the cost of the procedure. So the tendon healing is like a triad. So biology is important. As we talked before, the post-op stresses, so the importance of the rehab that we gave after surgery. And not least, the surgical technique and what kind of fixation we use. This is the typical suture configuration, and what we can see is like a triangular shape in which the tendon is securely fixed to the bone. And starting from all these hypotheses, we start to use what we have called the suture cross technique. We start from clinical, but we start from joke doing this kind of crossing the suture. But after we saw that during post-op check, the patient has less pain of those treated with standard single row or with double row repairs. So we hypothesize that the configuration, crossing the suture, can create a good footprint, and this give stability, enough stability to our construct, not to be able to give pain. And at least, but not the least, that the suture are not in line with the tendon during the motion. So we can also avoid the lesion created by the suture on the tendon. As we saw here, this is our cuff repair, and we see how crossing the suture we have a stable area limited by the anterior and posterior of the tendon in which it can heal. The tendon doesn't heal over, behind and over the suture, but in the midway where the tendon has less tension. Here is a prototype of a repair. You see here is a right shoulder, and this is I think the best type of repair for L-shape posterior lesion. We have put the first anchor down anterior, the second anchor posterior, and for me one of the tricks is passing the suture even in posterior part of the infraspinatus, like here, just to create a side-to-side repair for the posterior part, and this give an alignment of the tendon, on the medial tendon on the cuff. And you see how the stability, especially in the midway on the suture. And this is the principle, the parallelogram of fixation, that is the base of our construct, because bridging the suture create a self-reinforcing system and increase the tractional force, because if you see, the fibers of the tendon came in this direction, while the fibers of the suture are in oblique way against the tendon. So this is important not to avoid the lesion on the tendon. So we try to do a study on this, and we conduct a clinical study and biomechanical study. We use constant score and bus, and put to failure test and Copta area. This is the configuration. We use the transosseous equivalent, because when we do double row repair, we tie the knots on the medial row. And these are our patient, 50 patient for double row and 50 patient for suture cross technique. Medium was 28 months. And instead on cadaver, we have the possibility to study this technique on 4 human cadaver, and we create a crescent tear lesion of the calf, and then we repair with the suture cross configuration. We conduct with the instrument machine, and we have done a cyclic loading test, preloading and then cyclic loading, and pull to failure. That means that we pull till the end of the failure of the construct. So our constant score increase from pre-op to post-op at least 29 and 26 points, and the value are significantly so. For our statistic, and these techniques works both. And if we look at the data coming from the literature, the median, the average value is like us. We go from double row from 79 to 86. So medium is 81, and is more or less our value. And also with VAS, we have degrees of VAS to 2.0. The decrease of VAS was recorded as less than 4, and for both technique, double row and single row. And the subjective outcome was excellent or good in 27 patients. So this means more than 90%. We had pain persistent, 1 stiffness, and 1 anchor pull out. And this anchor was the posterior anchor of the suture cross. Even regarding the film revealer, you see the difference of our suture cross, that we have a good contact pressure, is not like the double row, but is pretty good. And also the load to failure test was recorded as medium as 3.309 Newton. That is very good. And we had in the 4 specimen, we have 2 bone break at the insertion here. So regarding the pull out is very good. And these are the load to failure tests that we found in literature. Obviously, the double row has very high load to failure test, and our value are put just in the midway between the double row and the single row study. So we can say that these are some preliminary study, and obviously we can't compare it with the double row fixation, but some value are very similar to double row fixation. And what is important, and then that we have an higher tensile load to failure strength, and this is higher than a single row fixation method. And what I would like to say that this is no an alternative to double row repair, but is just an improvement when we do standard single row repair. And seems that the outcome that we have from the lab are clinically reproduced in the group of these 2 patients. Obviously, what I would like for the future, I would like to try on more specimen, but one of the dark side of the specimen of the kind of age, the sex, the kind of the quality of conservation. We found that 4 specimens are not so good for a trial. The average in literature are 12 specimens, and we need the TEC scan, because with the TEC scan we have a more precise 3D footprint analysis that it's really impossible with the Fujifilm revealer. And the good things is that all this is an arthroscopic procedure. Maybe we can check with some outcome, but enrolling better the patient and the quality of the study. Thank you.
Thank you, Dr. Alberto. Is there any question to Dr. Alberto on his talk on single row repair?
Yes, Dr. Raghuvir sir has also joined. Dr. Sanjay Karthik is also there.
Yeah, I think Dr. Alberto has explained his technique very well, and it provokes thoughts, and it is quite close to his outcome in small series. Shows that the footprint compression area and rest of the parameters are quite reasonable, more than single row, but not as good as double row. So I think we need to really try this technique in our hand and have a little more experience about it. That is what I can say right now.
Yes, what I like is that I have some data that is more favorable of single row. And since we do single row for cost, for speed, whatever you like, why not change in this direction if we have good results from the lab? This is my thought. And these results encourage me to keep going. And we will see.
True.
The Crimson Dewey effect of this with single row technique, single row cuff repair technique, has been very well described by Dr. Mark Gettleman from SCOI. I think the SCOI technique, which was popularized by Southern California group.
Snyder.
Sorry, Sniper Snyder, not Mark Gettleman. It is, I think it is a wonderful technique, but only problem here is if you don't cover the footprint of the calf, the fibrous tissue what you get after from that Crimson Dewey may not mimic the original cuff, and sometimes you can have the tear from that tissue. So that is the only drawback.
No, I don't understand what you said.
See, the Crimson Dewey, the lateral footprint you make the microfracture, and medial row you make a single row repair, so that you can cover the healing process will form a good amount of fibrous tissue. But that fibrous tissue on the lateral end of the tuberosity may not be as strong as what tendon is. So eventually there is a breakdown. So I don't know how it works, you know.
No, one of the tendencies is this. Obviously, depends on the quality of the tendon, the retraction of the tendon. But one things when you do single row is not to lateralize too much the repair. So in this repair is stay little bit medial than normal.
Okay. Any other question?
Yeah,
Doctor. Yes. Hello.
Yes, Vinay.
Vinay.
Unmute yourself, Vinay.
His mic is closed. I think, Roshan, you have to open his mic from.
Yeah. I have opened it.
This is unmuted. Hello.
Yeah, Vinay. Vinay, you have been doing a lot of work on adipose tissue.
Yes.
And have you used these adipose tissues in shoulder rotator cuff, especially because the healing problem is very evident, and we are discussing single row, double row.
We have not. I have not used adipose-derived SVF in shoulder. Only osteoarthritis of the knee joint and some chondral lesions we have did it, because begin with, we have to do some clinical trial and all those things.
Okay.
So because of legal issues, we have not still started.
Okay. Yeah. So, is there any question to Dr. Alberto on the single row? Dr. Alberto, let me ask you. You showed the parallelogram and how it affects the single row repair, and then concentric pressure onto the tissue so as to press that tissue onto the tuberosity. But in single row, it will be always a point contact, as regardless to the double row. So
can we discuss on the parallelogram?
Yeah, we can discuss, no problem. But is it on your next presentation?
No, just for the parallelogram.
Parallelogram, okay.
The idea is this one. If you have the bone with the two suture, you stabilize the anterior margin.
I'll just show you, Alberto. So this is a single row. This is single row. Yeah, and this is double row. So amount of tendon back to the tuberosity in single row is very small, the point contact.
Yeah.
Whereas in double row, you have such a big contact from here to here.
Yeah.
So how does the healing will not affect in this kind of repair?
I show you which is the
so how does parallelogram work here? Because I never understood this.
Yeah.
Yeah, Sanjay, is it a valid argument?
Can you see?
Yeah, you can see.
So let him finish his argument.
Okay. This is the two suture. Look from this side. You look from the axial point. Instead, you look from lateral, like in this case.
Okay.
It's true that you have a small point of contact, but you have anterior and posterior part, and the suture that cross that stabilize this part of the cuff, this part of the cuff, this part of the cuff.
Okay.
And this is stable. Even when you have the suture put in the axial fashion parallel to the fibers of the tendon, when you abduct the arm, your tendon are just in line with the suture. So this kind of suture are very strong and can break the tendon. Instead, in this way, the suture are in oblique way to the fibers. So they can cut when you raise the arm, because they pull in oblique way.
Okay.
Clear?
Yeah.
Yeah, Roshan, I can understand what he's trying to say.
Yeah.
So it is not exactly the double row like construct. Agree. And coming to the Snyder's if I remember correctly, his couple of papers showed complete coverage of the entire footprint with the cuff tissue. The follow-up MRI showed that is what he has claimed, in this single row crimson duet technique. And Gettelman has been carrying this technique forward and giving, that kind of outcomes with follow-up MRIs. That is what it says. So it develops anthesis covering the whole greater tuberosity. That is what they say.
So, Alberto, my question is about the contact area, whether it's a point contact or it covers the whole of the full footprint.
The contact area is only what I have with Fujifilm Revealer, because much of the single row, but less than double row. You see, the stress and the pressure is concentrated around the suture and just close, because here start the suture going posterior or going anterior. You see, in this part, not too much posterior, not too much anterior. Just around the suture. But for this reason, I would like to test with TechScan, but TechScan here it's impossible. Impossible for me. One thing is I found at the university in US, but
Alberto, whatever you're saying is making perfect sense. I agree.
there is Vinay that want to say something.
Yeah, I agree. I agree that this makes sense. That rather than this single straight line, this line covers more ground, a little more than single row, less than double row, you know. So this needs more investigation and more experience for sure.
Vinay, yes, you have a question, Vinay?
Dr. Alberto?
Yep.
So how do you decide which cuff to go with conventional single row repair and which cuff to go with the cross suture technique?
How
do you decide which configuration, which cuff tier you would go with single row repair conventional method, and which cuff repair you will go with suture cross technique?
Okay.
Now, do you decide based on some criteria, or it's like
no criteria. My criteria is for repairable or not. So if I can repair,
so it's all cross suture technique.
I do when I want. I do always, because nothing changed to me for repairing the cuff. As you see, there is no difference from single or double row. It's just in my mind give some more opportunity and more stability to deconstruct. This is the only reason.
There are two questions came up on YouTube by Dr. Hardy. The first question is, Dr. Alberto, how was your experience at 6 months, 12 months, and up maybe 2 years in technique difference between single row versus double row? How was your experience of surgical repair at 6 months, 12 months follow-up with single row and double row?
Oh, just a moment, because you disappear.
Yeah.
I can see any other. No, my experience with this technique.
Hello.
Can you tell me?
Hello.
Yeah, he is able to listen to you. Yeah, go ahead.
No, I can understand your question.
No. There is a question on YouTube. What is your clinical experience at 6 months and 12 months with your two different techniques, single row and double row techniques?
Oh, I have some kind of repair and with both. But the problem is that with this technique, I had the possibility to do better repair, because what I have with the double row, three cases was type 2 lesion, that is the lesion in the midway between muscle and tendon. So where I put the first row, and this gives me some impossibility to repair. Instead, with the suture cross, all this repair is tendon, and this leaves me the opportunity to repair the tendon in a second repair. There is no much difference between two. I still do double row repair when it's possible, when the quality, as I said, the quality and the retraction of the tendon allows me to do in the young people. I mean, young people for me is till 15 years. After that, I do single row repair and I use this technique. 2 years, the results are very good.
Alberto, I just wanted to know, by repairing single row, are you not converting the rotator cuff tear into a pasta lesion? I'll give you an analogy. I'll just share my screen now.
If I repair pasta lesion,
No. I'll just show you.
So,
By
Alberto, in other sense, Roshan wants to ask, where do you put your anchors? Do you put those anchors
can
much
you
lateral or towards the cartilage?
can you
no,
see this?
I said I put the anchor near the cartilage. I don't go so lateral.
So, Roshan, it's not pasta lesion now.
So,
Okay.
eh, so if you see this picture,
Yeah.
even if you do your repair at medial side, you create the lateral cuff as a lateral defect.
Yep.
And if you put your anchor on the medial side, sorry, a lateral side, you are creating a pasta lesion.
I go close the cartilage, medial.
So medial. So you keep your lateral side completely vacant. So you don't bother about the lateral exposed tuberosity.
It
Yep.
is just crossing of the sutures. The anchor, which is on the posterior, repairs anteriorly, and anterior anchor repairs the posterior part of the cuff. So that is how he does. Otherwise, it is just like a single row and no crimson due added to it. That's what I understood. Correct,
Cre-
Alberto?
Is the following.
Yes.
Okay. So
I,
if yes, Dr. Anta. Yes.
Dr. Alberto,
Yeah.
that it is very important, I think, in your technique that the cuff tear has to be reducible. If it is not reducible, then it's a big problem.
Yeah.
Is it right?
Yes, exactly. In every time, the reason for single row, double row, everything works. Everything works. But the problem is quality of tendon and retraction of the tendon. Because what I don't want is suturing with tendon intraction. Understand me? I don't want suture with the tendon intraction. Okay?
Yeah. Hello.
Yeah,
Doc-
got it. I think
Dr. Anta, you got the answer? Yeah. So I think we should move ahead. Rajiv, we should go ahead with the next talk of Dr. Alberto. We have other panelists also who joined, Dr. Pratap and Karthik Selvaraj and Dr. Raghuveer. Raghuveer was here.
so. Now, Alberto is going to give presentation on the difficult to reduce and retracted or big tears or questionable repairability cuff tear, how to manage them.
Yeah. Did you see?
Yeah, we can see it. No problem.
Yes,
I'll
go
just
on.
mute everyone. Just a minute.
Perfect.
I'll mute everyone.
This is the summary. What to do when we have rotator cuff to repair, and this is the amount of surgery that generally in US does 250,000. It's very high number of cuff repair. So the problem is when we have lesion, the lesion progress with time. So even if it's asymptomatic, maybe at the beginning or in a late stage, we have a progression of the lesion. So this is our basic infra, supra, subscapularis. This is our basic, and what we have to keep in mind also in every time is the concept of couple force. For this, I am a follower of Dr. Burkhardt from San Antonio, and introduced me this concept. The concept are in vertical and in horizontal, we have a couple of forces that we try or we need to balance. And the other important things for me till today is the concept of rotator cable, because this allows me to do some another type of repair. And obviously, the cable means the theory of the suspension bridge on shoulder function. The problem is that when we try to define the tiers of the calf. Obviously, there is no question about partial tear, but when we talk about full thickness tear, we know that there is communication between glenohumeral and subacromial bursa. But the problem is massive tears. Massive tears is that when we are 2 or 3 tendons involved, or is bigger, like in this case, like the definition of Caulfield, than 5 centimeters. At the moment, there is no an agreement on the definition, and we saw that there is, when we talk about full thickness tear, different kind of classification based on morphology, on the tear sides, and also we have to look at what kind, if it is geometric or taking account the 3D dimension, the number of the tendons that are involved in the lesion, and this is from Harriman, the shape of the lesion, the size of the lesion by Christian Gerber, but we don't know for this classification what kind of treatment or what kind of prognosis we have, or the classification of Burkhardt, that is a geometric classification based on pre-op imaging. And also what's happened, so we have an arthropathy. If we have an arthropathy, so the clinical aspect of the lesion. So he gave us the indication if we have crescent type, what kind of treatment we have to go, and what kind of prognosis we may expect to that lesion. Obviously, when we have the last step, that is the arthropathy, rotator cuff is irreparable, and we have to go with arthroplasty with variable results. Or the classification of path, in which taking account the extent, the topography of the tear, the topography of the quality of the muscle, the state of the long head of the biceps, but the great part for which path is recognized is this photo, in which we can see the retraction of the tendon close to the bone in the medial of the head, in line or back to the glenoid. Also, Boileau make a classification like this, and Snyder, the simple classification with articular, bursar, or complete. Another important thing that we have to take in account when we look at the repairable of the calf is the fat infiltration that we heard at the beginning of this meeting. So it's important to understand the functionality of the tendon, because obviously we can expect more function from grade 4 or fatty degeneration. We thought about 3D because it's important to try to imagine or recognize the pattern of the lesion, because this allows us to give the information. The best thing is to give the information to the patient on what kind of procedure we are going to do and what kind of result he can expect. And obviously, this reflects on how we can improve our clinical outcome. The foot thickness tear is frequent, really frequent, and at the age of 70, 18, or more than 18, 80% of the patient has full thickness tear, while the partial thickness tear is more frequent in medium age. Tendon degeneration is another important thing that we have to check, and this is correlated to the age, to the work, to the sport. Obviously, going with the age, there is change in structural component of the tendon, and second, the concept of a critical zone, that is a zone of hypovascularity of the tendon, because we have to imagine that during abduction and with the arm at rest, we have some compression given to the calf. Other important things that we have to know is how the calf has a lesion. Is there a traumatic lesion or is an atraumatic lesion? Because these reflect the quality of the tendon and the what we can expect in the future. Obviously, if we have a chronic calf tear, this means that is presented for several months, and we may expect atrophy on the muscle. We may expect bad quality of the tendon. So we have to think if it's good, go to a surgery or try to proceed with non-operative treatment and try to reestablish some function of the calf, especially for the deltoid. But in this case, we have to understand if this is a calf that is weak, and so try to reestablish the force of the muscle, or is this shoulder is stiff, because this for me is in another point, crucial point, to decide if operated or not depression. And at this point, I want to say that for me, decompression or only acromioplasty is not worthwhile for the patient, because what I'm afraid is, and I come back to the principle of Burkhardt, is create a lesion or to the coracoacromial ligament that is the superior restraint for the humeral head. So what I want is the superior escape of the head. And what we have to look, if the patient has pain is important, or the patient is bothered by functional impairment, or both. So we have to check which is the major complaint of the patient. Second, as I showed you before, the great tuberosity is the weakest point of bone of the humerus. So we have to think when we go with repair, because it's better that we check with the pull out the strength of the bone instead of find a situation like this after surgery. And this is one of the failure of the suture cross repair that I showed you before. Also, as I told you, the muscle is important, because the muscle is our engine of the shoulder. So I can expect much function from grade 4 of fatty degeneration. And another thing is the level, the skill level with some advanced technique. So the physical examination, we have to check the patient, because pain comes from shoulder, but not always from rotator cuff tear. So we can check especially the long head of biceps, that is pain generator in this case. We have to check the passive motion, especially in abduction and internal and external rotation, to check the contracture of the capsula. And there was a tendency in Italy to do many Mumford procedure, but we have to think that AC joint, especially in massive calf tear, the AC joint is overloaded. So the pain doesn't came from AC, but came from the overload given by the tendon. The other things is what kind of active Rome, if present, difficult, or is absent. The radiograph are important because we check for arthrosis. We can check how the head move upward, the degeneration of the AC joint. So there is something to check. One thing we do is we have done this for study. This is a superior escape on the left, so the patient can move anymore. Instead, on the left, you see the patient how in the presence of big tear, the head can go. You see the head goes up, take rotatory movement on the acromion, and then the patient with the move also the help of scapulothoracic joint motion can help the movement of the shoulder. What is instead is impossible on the right side. You see the head goes upward and take point there, but it's impossible rotate. We already talked about the muscle atrophy. This is the degeneration that we heard before. Just to think that this is irreversible. The retraction is important. I always outline the quality of the tendon and the retraction because I want to do repair not with the suture interaction. And you see, this is an old video, but I like to check the retraction. What are the indications? Full thickness, acute full thickness. I generally try to operate immediately. And when instead I have chronic tear, that I try with conservative treatment. We talked before, if we do some cortisone injection, if I have in mind do not repair the patient, I can do 1-2 cortisone injection and see what's happened to the patient, or even patients that are impossible reoperated. But for the basis, what I would like to try is a rehab, especially for the remaining calf and for the deltoid. And any full thickness tear, I repair any full thickness tear in a young patient. I try to repair when it's possible, obviously. I try to repair all the calf tears, but the problem is that not all the calf tear are possible to repair. So I try to give a chance to the people, even if the patient is already operated. This is not a contraindication, but in this case, I will check with image if there is any rotator cuff disponibility. And in my mind, what I try to do is keep everything I do in a simple way. I don't want to do strange things. I want to do as much as simple, keep as simple as possible. Again, what I want to outline is the range of motion, and then I don't operate the stiff shoulder because I may have a suboptimal repair, and the patient with a stiff shoulder complaint is a big problem to deal with. So I use ByDr for repair. When it's possible, I do an adjunct capsular release, and the tendon, I repair the tendon where the tendon wants to go. I don't put the tendon where I want the tendon goes, but where the tendon wants to go. When it's possible, I told you that the stitches I try to put in oblique way to decrease the tension on the interface between tendon and suture, and I try to keep much bursa as possible to maintain the biology. This is one the principle of Burkhardt about the release, and the coracohumeral ligament is possible to release at the base of the coracoid, but for example, I don't want the single interval slide, a double interval slide, because this gives not to me much chance of healing, and also there is no advantage and better improve of the integrity of the tendon. So I don't do this kind of release. Questionable is the principle of suprascapular nerve release. For me, when I repair, I don't do suprascapular nerve release except in the presence of atrophy of the infraspinatus fossa. In this case, I can do. One important thing in rotator cuff repair is deal with a long head of biceps, because if I repair the tendon, I don't want the biceps in the middle, because I don't want that windshield effect that can create damage to the tissue that is going to repair, and maintain the pain of the patient. So what I do is tenotomy of tenodesis, and always check if the long head of biceps has some kind of instability, like in this case. I don't leave the biceps like this, but I proceed with the repair. There is some advantages in both tenotomy and tenodesis. Basically, I do tenotomy in women and tenodesis for men. This because I want to avoid the cramping effect, the fatigue effect, the fatigue pain that comes after tenotomy, and because generally the men are I request that doesn't have the women. So I can do when I do tenotomy, simple tenotomy, or with a small incision, I do subpectoral tenodesis. It takes 10 minutes more of surgery, and there is no problem at all. Tendon infiltration, tendon retraction is important, and you just want to see when the repair is not possible. This is the question, because when it's possible, I think that everybody can do something. Also, in this case, we have our principle of what to do. We have patients with big tear that we go with a non-operative treatment, just rehab, and the patient goes well. Other, we have patients that have pain, that loss of function, and in this case, we have to think what to do. For example, what I do is augmentation of this graft for repair, and my colleagues instead like the tendon transfer, especially the latissimo dorsi for supraspinatus or external rotation. I follow the principle, as you saw, of Burkhardt, and when I have big tear, but for me, it's possible to reestablish the cable. That means that I have good anterior subscap, and I can do something with the infraspinatus, reapproximating the upper part of the bone, the anterior part of the supraspinatus. I do what he called the partial repair, and in this way, reestablish the cable leads to increase of function of this shoulder. But when this doesn't work, we have two more other option. One is the so-called the balloon, that is just poly PLLA polymer that is inserted beneath the acromion, beneath the between the head and the acromion, and this is a spacer that degrades in 3-5 months, and keep the head lower and increase the possibility to rise the arm. And the same principle was given by the graft, is the so-called SCR, that is superior capsular reconstruction, and I do when it's possible in patient 16 years when I have big tear, irreparable tear, and there is no arthritis. This is what I do. Miata change this principle, adding an anchor on the medial side just beneath the long head insertion on the tubercle of the glenoid. The procedure is not so difficult, but is a little bit tricky because we have many suture in our operation field, and the basic is start with fixing anterior, putting 2 or 3 anchor, one anterior, 2 o'clock. We can put another anchor just in the middle at the attachment of the long head of biceps, and another in the posterior part. The anchor in the posterior part is a little bit tricky because there is the spine, and you see I lift this because there is little bit difference on the angle in which you perforate and the angle in which I put the anchor. In fact, you see that the anchor doesn't follow the same street of the hole, but fortunately I was able to push again the anchor inside the bone. So it goes inside. I put little bit upward than normal because I don't want the dog hair behind the long head of the biceps anchor. And for this reason, now I add the third anchor, and you measure the distance between the 2 anchors, because these are the distance that we want, that we need to recreate on the graft outside the here the arthroscopy. So when you check all these trapezoidal shape of the measure, we can start fixing the the graft. You see, this is the distance between the first row, 40, anterior and posterior. A little bit anterior. You check. This is our first row, and this you see how many suture you have into the field. So now I think it's the time to pull the graft inside the joint, and this is the worst part of the procedure, because you have to recognize all the suture and leave that the graft goes where you want. And start to tie the suture to fixing the anterior part. And the posterior part. And then we go with the second row, grabbing the suture of the first row of the anchor, and this is the self-punching anchor, and you go inside, and this is the last part of the procedure, suturing the posterior part of the graft with the infraspinatus to recreate the posterior margin of the pseudo cuff. You see posterior, medial, anterior, and here on the back there is the lateral part with the second row. And that's it. This is one of the procedure that I say that I want to do. That is the acromioplasty, because I don't want the superior escape of the head. And this is the last. That is the tendon transfer. I don't do tendon transfer. Eventually, I refer to my colleague, especially with young active patients that have loss of strain and pain, obviously related to the loss of this muscle. There is no presence of arthritis, and with the transfer, we want to recreate the opposite function of the muscle. So the fourth scalpel of Burkhardt is again present, even in this case. The bone quality is important because it has to keep the fixation, and the compliance in the patients of the patient, because this required a long period of rehabilitation. Thank you.
Thank you, Alberto. That is a wonderful and very, very comprehensive talk on massive rotator cuff and retracted rotator cuff. I think the paper is open for discussion. Hello? Can you hear me?
I think it was an excellent presentation.
Yeah. So all of you can ask questions to Dr. Alberto. Now we have a discussion time, almost 15-20 minutes.
Alberto, can I ask one question?
Yeah, please.
Alberto, what is your longest follow-up for the...
Increase the volume.
You have to increase your volume.
Yeah, or you can lean forward. Yeah.
Yes.
Okay.
From mobile. Yeah.
Yeah. What is your longest? What is what is your longest follow-up for superior capsular reconstruction?
Now 3 years.
Okay. And the rehabilitation, is it completely different from the arthroscopic rotator cuff repair?
No, what you said is
No,
different.
Rehabilitation.
rehab is completely different than rotator cuff repair, or it is same as our rotator
No,
cuff?
I try to use the same principle of rotator cuff repair. I want to use some period of rest and then regain the passive movement. The problem is that with the patient, basically, I have from 3 to 6 months of more pain, more difficult movement respect to the cuff. This is the 6 months, even if I use the same principle of doing quiet, it's painful and is more stiff. I find more stiff in SCR than in rotator cuff. So this is the only difference. But at 3 years, really 3 years and a half, the results at the moment are good. They are NARS and I dresser. All women. I don't know if women are more prone to stiffness, but this is my experience in this.
Thank you, Alberto. Thank you.
Which graft you are using, doctor? Which graft you are using?
For SCR.
SCR, porcine graft from Artex. But just this year, I talked with my colleague from Spain, and maybe I will translate it with IT band, T-band, and I triplicate IT band, and I will try with that.
IT band, fasciolata, these are the commonest graphs which can be used.
Yeah.
Yeah.
I will try
Thicker also, so we'll give a good superior. And would you do you repair the graft with the infraspinatus by 3 or 4 sutures?
With the infraspinatus?
Yeah, graft with infraspinatus.
Yeah, with the infraspinatus, close side to side.
Just side to side closer. Yeah.
With SCR, it is always advisable to close the posterior gap between the infra or teres minor, and you can get a better result, because if you leave it as it is, then it is a very high chances that it will fail. Yes, Dr. Antao, you have a question, Dr. Nicholas Antao? Can you hear me, Dr. Nicholas Antao? You can press your space bar.
Sir is not here, I think.
Are he left? Okay.
He's not here. So,
yeah, Dr. Albert.
Yeah.
Roshan, can I ask one question?
Yes, Samir.
Yeah, like after SCR in SCR, whether you are using for pseudo paralysis of the patient?
Sorry, if I use
pseudo paralysis.
What is your indication for SCR? Pseudo paralysis is one of them.
The indication of massive tear with supraspinatus tear and partial infraspinatus tear, and what I don't want is the presence of the lag sign. Job test positive, Whipple test positive, but the patient can keep the external rotation.
So no pseudo paralysis, correct?
No.
Dr. Alberto, there is a paper by Dr. Laurent Lafosse where he has used the balloons after the rotator cuff repair so as to get additional spacer effect.
I don't have experience with balloon because I use at the beginning of the balloon, but probably for my experience I have because I don't choose the right side, so I have movement of the balloons, and I need to retire the balloons, and from that point I never use the balloons. But I had friends that was operated, close friends that was operated with the balloon, and they improve pretty soon. So I saw that now there is another company that are distributing the balloon, and one of my thought is to restart to use the balloon in this case.
Alberto, basically, I wanted to ask you, in Laura Lafo's paper, what he says, he uses balloon as a protection for his rotator cuff repair, and so that he can get a better biomechanical result and healing result because of good biomechanics and maintaining the space, the subacromial space, and probably that is the reason why he gets a better result. So, do you agree with this analogy of using balloon for as a protection?
No, I tell you why. Before we talk about the vascularity of the cuff, and I don't want anything that keep something pressure on my repair. If it want to works, should be anterior and posterior couple of folds that keeps the head inside, but not nothing can press on the cuff. I don't know if this is reason of market or something else, but not in my mind.
Yes, Raghu, you have a question, Raghu?
Yeah, Alberto, one question. What are your indications for balloon? If you ideal case for balloon.
I don't use balloon, so I can give you the indication. But for me, the indication are pretty the same of superior cuff. Superior capsular repair and balloon are the two system in massive rotator cuff tear.
Superior capsular repair, who doesn't want surgery?
Sorry?
Superior capsular reconstruction, who doesn't want surgery? That is the indication?
With the cuff repair?
No, people who doesn't want surgery is also indication.
Just for pain relief, you can put balloon there. I think Raghuveer is asking this.
People who don't want surgery, I try with one cortisone injection and rehab as much as possible. In this case, it's the people that ask you to be operated. You give the indication, but if don't follow you, they need to try something else, and they come back to you and say, okay, I am ready for surgery.
Yeah, Vinay.
Yes,
Dr. Alberto. Hello, Dr.
Yeah.
Alberto. So the video that you show, the posterior anchor and the glenoid had a trajectory problem. There was some problem in the trajectory of the anchor on the glenoid, posterior anchor.
Yeah.
Yeah. So would you like to give some tip regarding to improve upon the trajectory of the anchor that we are going to put on the glenoid, posterior anchor?
Yeah. You see my video?
Yes.
In the middle, I have a dog hair. Now what I change this kind of procedure, and I put the anchor a little bit down, and I put the third anchor in the middle, going from here, from superior portal, and I go straight there.
Navasier portal.
Yeah, you can go through Navasier portal.
Exactly. With the two suture, I cross the suture outside, so I pull the other two, and I bring the graft inside. And then I close. In this way, I have two effects. One, I don't have the dog hair superior. I put the anchor more easily in the posterior part of the glenoid, and all the graft is just rounded along the scapula, the glenoid.
Yeah. Alberto, you spoke about suprascapular nerve release in massive cuff tear. In fact, there has been now debate because initially when we started with massive rotator cuff repair, initial wisdom was to do suprascapular nerve release and then only you repair it. But now people have shown that even if you do release or you don't do release, there is no technically a difference in clinical outcome. So any comment on that?
Exactly. I say that I don't do suprascapular nerve release in rotator cuff repair, except if I have hypotonotrophy of the suprascapular of the infraspinatus. This is the only case that I do release of the nerve. but not in rotator cuff repair.
And your experience with this patch graph, because my experience with patch is horrible. In fact, I stopped using it. Initially, I used to do all my SCR with the patch, and then suddenly we started getting tremendous infections. So we completely stopped using it, and now we are back to the fasciolata. What is your experience about this patch? Because I saw your both videos, and your X-rays are with the patch.
No, fortunately, I don't have infection. Fortunately, and at the moment it's good. But the problem, for the reason, if I want to switch to fasciolata, is only economic reason. And the other is a derma graft. So this is the two main reasons, changing from economic and for the result that this colleague showed me with fasciolata, that less stiffness after surgery, and these are the reasons that I want to change.
And when do you decide about doing reverse shoulder replacement? When do you decide to do a reverse shoulder? What are your indications of considering reverse shoulder replacement as a surgery for massive?
Age of the patient. After because this is a reverse procedure, and at least at 70. Even the age of reverse shoulder arthroplasty is decreased. We see in Europe that there are some guys that use reverse also in more younger people, but I try to wait as possible.
Yes, Vinay.
What's your take on performing interval slides for massive retractor cuff tears? Do you believe in interval slides, anterior and posterior?
No.
No.
I don't believe it, because the results are the same. So you have more strain on maybe some kind of also vascularity in the tendon. So I don't do interval or double interval slide.
Okay. Are there any questions, Rajiv, Jayaprasad, Samir, Raghuveer, Pratap, Sandeep, and Vinay? If there are no questions.
Yeah, Alberto, since I agree with Roshan, because you are using the graft as a spacer. So tensor fasciolata, usually you get a thick graft than what you get in these patches.
Yeah, TFL, the fasciolata, you can get almost 4 to 5 millimeter thickness graft.
And I think
and patch, you can get almost 2.5 to 3 millimeter graft.
Okay. So I think as a spacer, if you want a thicker part there. So I think works better.
Yeah.
Patches.
So if there are no questions to Dr. Alberto, I'd like to thank. I have already made the meeting stream. I'm just stopping the meeting stream, and I'd like to thank Dr. Alberto Constantini for his wonderful lectures on rotator cuff, and Dr. Jayaprasad for his wonderful insight on how the cuff healing. So it was a wonderful session. We all interacted in great details. I'll just stop the live streaming so that